Well, thank you very much for the introduction. So first of all, I have to thank the organizer for having me here today. I mean, imagine, I have never imagined myself standing on the stage in the HIV forum. I'll tell you why later. My topic today is the clinical management of aging patients with HIV. I'm going to start with my disclosure. I do not have any relevant disclosure to this talk. And why? Because I like to declare myself first that although I am an ID specialist and geriatrician, but I am super duper small in the field of HIV because my research, actually everything is focused on the non-HIV. But anyway, I've got something to share with you today. So my talk today will be divided into two parts. The part one, I think it's going to be really nice to know something about the changes in aging so that we have some basic, and then we combine the HIV infection into aging later in part two. All right, we'll move on to part one. Here's the outline. I'm going to briefly talk on the introduction in terms of aging. We'll touch on the biomarkers of aging. Immunosenescence. We'll learn a lot actually from Professor Sabin. I like to get rid of my slides, but I've got no time. And also with the changes in immune function associated with aging. And lastly, we'll end up with the aging with the overall infections. I mean, as we all know that we are in the aging society, it is true not only in the Western countries in the US, but it is also true in Thailand. I mean, when you go up to the floor, the regular wards in your own hospitals, I mean, we see that a lot of people are age over 60, 65 years old, something like that. According to a survey from a couple of years ago, more than 800 million people worldwide age over 60 years old. And that particular number is actually 4 times higher than a survey back in 1950. When you live longer, it doesn't mean that you're going to stay healthy forever. I mean, a lot of bad consequences can occur, starting from higher prevalences of infection, cancer, neurodegenerative diseases, or even cardiovascular diseases. Some believe that all of those could have been affected by a matter of changes from the immunity, either from the innate or adaptive immunity. And again, when we grow older, a lot of people believe that we do have a condition called a decline in our immune system, or we call immunosenescence. We talk about that later. Just would like to recap with you a little bit. When we see the patients in the clinic, particularly when you see the elderly people, besides taking a physical exam, history and a physical exam, you may need to perform something we call physical function assessment on them as well. What are they? So basically, you need to look at their walking speed. You need to measure their grip strength. You need to analyze the chair stand, because all of those can be indicators of the overall mortality among the patients. But if you will perform some blood tests on them, many times you can realize that they are in the state we call chronic inflammatory process. You're going to see a slight elevation of the pro-inflammatory cytokines, for example, interleukin-6, TNF-alpha, or even CRP. Or if you can look at some simpler lab like the vitamin D level, the low vitamin D level can be another good predictor for neurocognitive impairment or even the overall mortality as well. And if you are a basic scientist, you would like to find more about the root of the problem. A telomere can be probably the way to answer the questions, because telomere length can be another good explanation for the biomarkers of the aging, because sometimes we can really predict the mortality from the telomere length. We'll talk about that later as well. All right, and what is immunosenescence? So basically, it is the aging of the immune system. What I've written here, that aging of the immune system is not necessarily linked to chronological age. So that means when you're old, it doesn't mean that you're going to be so weak in terms of your immune response. Even when you're young, it doesn't mean that you're stronger than the older population. All right, this is a fact that we need to remember. We keep that in mind first. And what causes immunosenescence? I mean, we learned from Dr. or Professor Sabin already about the CMV. It's been long known that the CMV, or the chronic infection from a virus CMV, has been listed as a cause of the immunosenescence. Apart from that, it could have been from the physical or psychological stresses, chronological age, or even obesity as well. All of these can drive yourself into an immunosenescent state. And I touch on the telomere. I mean, and what is a central role actually for telomeres? So basically, I mean, if you imagine your chromosome as a shoelace, there are two ends of the shoelace, right here. Probably you don't see that. But anyway, it is just right there. All right, just imagine the caps. So the shoelace actually are the places for a telomere. If you would like to have your chromosome intact without any damage from any environment, from anything, you need to have very long or good size of the caps, right? I mean, again, the telomere would do that job. And the enzyme telomerase is the enzyme that helps to lengthen the telomere. When you grow older, we'll believe that the telomerase function is not going to work so properly. That means, I mean, you tend to have shortening of the telomere when you grow older. There's a quotation stating that here, that the telomeres are just like biological clock. As they shorten, the senescence can take place. Because, I mean, we are in the environment that we have a lot of exposures around us. I mean, not just only from within, I mean, but also from outside. When we are in the sun, we're exposed to the sunlight, we're exposed to the UV, or even from the radiation. Or the stress from within, for example, right now I have a lot of stress talking and the HIV among the people like here. The ROS, or the reactive oxygen species, can drive yourself into a status of the DNA lesions. If we have a very good repair pathway, or we have an intact the telomere length, we probably can fix those conditions. But if not, probably, I mean, the repair pathway is not going to work properly as well. And why do we care about immunosenescence? A lot of people believe that people with immunosenescence would have higher level of the pro-inflammatory cytokines, and that was believed as well that has been caused of the atherosclerosis, type 2 diabetes, or even Alzheimer's disease. Not just only that, because we are infectious disease. The infections can be higher as well in terms of their incidence and prevalences, and the response to the vaccine can be reduced as well among those people. Or even cancer. You know, with persistent inflammation can increase the risk of cancer and its progression. Because, and then what does immunosenescence look like? I mean, you may want to know about that. So when we grow old, right here, you know? I mean, at some point, you know, we're gonna enter into a state called immunosenescence. And also with a lot of comorbidities like endocrine function, diabetes, or neural function dysfunction, or cardiovascular disorder, all of these would coincide with the immunosenescence. And then it can lead you into a bad shape. I mean, you tend to get more infection, you tend to have some sort of the cardiovascular conditions. The characters of the immunosenescence, like you're going to have a lower naive CD4 T cell. You do not have a great ability of the immunosurveillance. If you do have a bad phenotype within yourself, for example, you do have CMV seropositivity along with the ratio of CD4 to CD8 of less than 1, all of these things would be bad combinations and drive yourself into these very bad consequences, infection, cancer, or even frailty. As I told you before, that immunosenescence, it causes a lot of things. In terms of the innate immune response, I mean, it started from your skin and mucous membrane. The complement and the PMN function won't work so well as well in such condition. And not just, oops, sorry, no. Sorry. I go back. All right. Now with adaptive immunity, a lot of bad things can occur as well, starting from T cell and NK T cell. They don't work so well. Same thing on the cytokine production. Everything would be distorted. So when things were bad just like that, you can really imagine that, you tend to get more infection rates when you compare to the younger population or when people without immunosenescence state. You tend to have reduced clonal expansion of T cells specific for chronic viral infection, particularly CMV infection. Or even if you're going to vaccinate a person with immunosenescence state, you won't expect to have a great number of the antibody production. Same thing, with the skin and mucous membrane impairment, the slow wound healing, that is something that you would expect. So I think, that's going to be a very quick review on the changes on the people with age. And then we move on to part 2, which is the HIV infection and aging. This is the outline. We're going to go through it shortly. It is also true, not just only, we see the general population in our country who are older than 60, 65 years old, but people with HIV infection or AIDS diagnosis, they're getting older as well. A quick survey from the US back in 2016, the report that the people who were diagnosed with HIV or AIDS diagnosis, more than 50% of them actually were recorded to be older than 50 years old already. And I've seen many patients in my clinic actually right now, they are older than 50, even 60 years old. My oldest patient with HIV right now is 84. And we need to realize that, despite we do have a lot of medicinal regimens to treat them on the viral suppression, but somehow the life expectancies among people with HIV positives remain shorter when we compare to the HIV negative individuals. And partly could have been from the HANA or the non-AIDS condition, and we believe that the HANA occurs earlier and more frequently or even more aggressively in HIV negative individuals. We believe that, people with HIV-positive individuals that do have a condition called the elevation of the inflammation starting from cellular or dissoluble markers. And those changes, actually, we cannot really reverse, even though you're going to suppress the virus completely. That means if you're gonna draw the blood from your own patients, you still can see the changes in the expression of the activation marker on T cells, or a lot of things, or even on the monocytes. We believe that with these changes or this regulation could have been from the apoptosis or necrosis equilibrium that has been distorted of the innate cells. So massive immune activation may be the key to explain all of these changes. When we talk about the ongoing HIV, the viral replication, or the gut microbial translocation, or even a very important factor that Professor Sivan had mentioned, which is the CMV co-infection, that is very important, and also with the immune dysregulation or the immunosenescence. But we cannot really blame on just only the physical part, but we need to blame on the patient's behavior as well. If your patient is a smoker, if they drink liquor or something like that regularly, they tend to have more infection or inflammation ongoing. For example, people who smoke, they tend to have increased oxidative stress. If they drink alcohol regularly, they tend to have microbial translocation more often. Or even with the co-infection, CMV infection, all of these things can drive themselves into a chronic inflammatory state. We talk on the gut microbiome and also the role of microbiome and why. The microbiome in HIV would be another thing to discuss, or that could have caused the chronic inflammation inside the circulation of the patients. So basically with the HIV replication, and at some point, we do have gut translocation all the time, not just like in the patient, but also in ourselves. But in these particular condition, when we have the gut microbial translocation, your body will need to tackle the pathogens, right? By bringing in the macrophage and dendritic cell to create the inflammation and try to stop the pathogen from invasion. So we're going to create all the inflammatory cytokines, the TNF-alpha, interleukin-6, and IL-1 beta to create the inflammation. But we need to have more specific immune response, so we need to call T cells to get activated and proliferate. Eventually, when we live in this condition long enough, eventually your T cell will be exhausted. So, along with those conditions, eventually your T cell will enter a state we call senescent T cell. So plus with the inflammatory process ongoing, that means, eventually people propose that it can create a lot of conditions called the cardiovascular diseases, neurocognitive impairment, or even the metabolic disease. In summary, so with the microbial translocation, residual HIV viremia, and the co-infection of the CMV infection might be the answer to activate the monocyte and create the inflammation, and eventually can cause serious non-AIDS events. That can be something that is very important for the patient that can have HANA conditions. Another thing, the effects of aging and HIV infection, it is a very nice review from this study stating that if you're going to vaccinate the patient who is young and negative HIV serology, and they measure the antibody production, in this population, actually they can produce a lot more antibody when we compare to the older population with seropositive HIV. And they tried to explain why they found that finding. It could have been from the background, the immune activation among those population, because they do have like B cells and T cells activated all the time. So they do not have the way to make antibody correctly or properly when we compare to the younger population without HIV-positive, without HIV infection. It seems like immunology can explain a lot of things, but we do not know yet at this time that it will be the answer for everything in aging HIV patients. But at least if we're going to tease out by the immune category to compare, to make a comparison between HIV infection and aging, starting from the pro-inflammatory environment, we can see that they share a lot of similarities, starting from the pro-inflammatory environment. People with aging and people with HIV infection, they do have increased level of the interleukin-6, TNF-alpha, soluble CD14. They do have higher level of the coagulation factors or even acute phase reactants. Same thing that we can see in the monocyte part. That they have inflammatory CD14, CD16 on monocytes. They do not have a great phagocytic function in both entities. Same thing that we can see in dendritic cell and TLR pathway. With the overall interferon alpha production is much less in both populations. And now, I think, we've talked about that already, this HIV accelerated aging. At this time, I'm going to say we don't know, but, we try to explain a lot of things, whether it is the true answer. But here, a lot of factors actually can affect the aging among HIV population, starting from genetic instability, the telomere shortening from either from HIV infection itself or from the aging process. And lastly, with cellular senescence would be something that is interesting nowadays. And of course, when we take care of the geriatric population without talking about frailty, it's not going to be a complete one. So frailty in geriatric population, it is another concern that we need to discuss about. So frailty is a state of the increased vulnerability of old age. So they do not have a great reserve. So that's why they tend to be frail. So frailty is not equivalent to disability. Why I'm saying that? So when you have a person, and if you like to make them disabled, just chop them limb out, and then that person will become disabled. But that it doesn't mean that that particular person would be frail, all right? So frail people, they do not have a great response to the stressors. They cannot really react well, but disability or disabled people who are not frail, they can respond to the stressor more properly. And with the frailty stage, it can lead to a vicious cycle towards functional decline and other serious adverse health outcomes. And eventually, frail people can turn into disabled later on in life as well. The prevalence of frailty among geriatric population is quite high. Again, it is another survey in the US. If your patient is older than 85, the prevalence can be over 25%. We do not know yet in terms of the frailty prevalence among people who are aged with HIV patients in Thailand at this time yet. So that means, the frailty is a very important issue to discuss among aged HIV population. So that means, the functional status assessment is just very important because the functional status is one of the predictors to tell the mortality among the patients. Because people can enter frailty state earlier than HIV-negative patients. They can have a lot of higher burden of these psychosocial issues. So in terms of taking care of the HIV patients who are aged, perhaps, to perform only the HIV routine care HIV might not be adequate. We perhaps need to call the geriatrician or to have the way of the geriatrician taking care of the patient, combining into the HIV care. That is probably the way to go at this time. I think I'm going to skip this one. All right, and a lot of comorbidities that we can see in HIV disease, cardiovascular disease or metabolic conditions like diabetes, pulmonary disease, renal disease, bone disease, for example, osteoporosis, or even malignant disease. Not just only from the physical part one as well, talking about the mental health. People who are aged, they tend to be more anxious than younger population. They can be depressed, sometimes for no reason, or, and also with the medicines they've been using as SRI for anxiety. And sometimes the prescriptions that you prescribe to the patient, for example, an easy medicine, FFR, and sometimes it can create excessive aggressiveness in the patient, higher rate of the agitation, something like that, that you need to be aware of the side effects of the medicine prescribing as well. The cardiovascular diseases, atherosclerosis, sometimes we believe that it is it can occur prematurely, or it can occur faster when we compare to HIV-negative individuals. So that means if you can reverse or try to prevent the cardiovascular risk, you may need to be very thoroughly monitor your patient, checking on the lipid profile maybe every 3 to 6 months or so. And you need to discuss with the patient if they are still smoking. You need to talk to them not to smoke. And you need to manage the diabetes very nicely. I think in this slide you already know what medications can cause hyperlipidemia. So just like to remind you that, with the medicines we're giving, it might be another drive for the patient to enter atherosclerosis faster. Osteoporosis, not only the TDF prescription, but also chronic immune activation, low vitamin D level, hypogonadism, or even the smoking can be additional risk on the patients. And immunosenescence versus the NeuroHIV, I think we learned about that already. It is not something you're going to see early on in the disease of the infection, but if your patient enter into certain state, they do have persistent chronic inflammation, neuroinflammation, something like that. They can enter into the neurocognitive impairment state at some point. So that means, when you see the patients who are like older than 60, 65, taking care of them, you're not going to ask them just only, okay, you take the medicine, how you're doing. You probably need to ask them more, are you more forgetful? Something like that. You need to perform the MMSE at some point, at least to screen in their cognition, so that you know more about the patient, whether they are demented already. So In terms of taking care of the aging HIV-positive patients, I'm going to say there's no comprehensive or a complete formula to take care of the patient, but perhaps you need to create your own treatment strategy depending on where you are. But you need to really consider to combine the geriatric care into a routine HIV. So I think that's going to be the way to go, and you need to really consider the role of the multidisciplinary care. And if you do not know where to start, I'm going to recommend you to go read more detail on the UCSF Silver Project. I think it is a very good example for you to learn from. Drug-drug interactions are another issue that you need to discuss because, the elderly people, they tend to take a lot of medicines on the list. Polypharmacy occurs all the time. Again, if you do not know or if you cannot remember all the metabolic pathway, it's very easy. Just go on to this website, check it, and then you know what to do on your patients. So, and also another thing to discuss, the medication adherence. When you take care of the younger population or the adolescent HIV-positive individuals, you deal with a different problem. They do not want to take the medicine. It's from their lifestyle. But when you take care of the elderly people, they do not take the medicine. It could have been from their depression, or they do not have a good support from the family, something like that. They cannot see things clearly. Those limitations, something like that, it can stop them from adhering to the medications. Or even drug abuse. If they drink alcohol at home, all of those things can stop themselves from adhering to the medicine. So if you would like to enhance them to comply to the treatment, you need to perhaps arrange the education class or session so that they know the importance of taking medicine to control the disease to get well all the time. If you can provide them the organizing devices, many times they're confused. They do not know which medicine to take at what time or which one to take at this time. When they have the list of medicine like 10 or 15 for one day taking. Reminder devices, you might want to suggest them that, okay, you need to have this device or you need to have some alarm to take the medicine at a certain time. And try to get family members or caregivers involved, so that you have more responsible people for the patient. And I think I'm gonna stop my talk with the suggested management for new HIV, especially when they're old. Besides taking care of them, like taking a comprehensive history and a physical exam, routine blood test, checking on the CD4 cell count, you need to look for the fasting lipids and screen on the cardiovascular risk, looking at the urine, check on their kidney function. Do not forget about the vaccination. Check on the fasting glucose to screen for diabetes. And you need to discuss with them on the mammography, colonoscopy, or even lung cancer screening if they do have the risk on, or even the abdominal aortic aneurysm if they are at risk. So I think I'm going to stop here. So in summary, I'm going to say taking care of the aging patients with HIV, it's going to be really nice to combine a geriatric care into a routine HIV care at this time. Thank you.